I will let you know when we are good to go. You can welcome the participants.
Great. Are we live now, Lucas?
Yes.
Oh, can we go back to the previous slide, please?
Yes, just a second.
Great. Well, hello everybody, wherever you are and whatever time it is. Thank you so much for taking part in and joining this webinar, which I think is something like the 23rd webinar we have organised as the global platform on coronavirus and older adults in low and middle income countries. And most of our webinars in the past have focused on particular issues like the mental health of older people, social protection in older people, but occasionally we have sessions which, instead of focusing on a theme, focus on a particular country. So we've had sessions looking most recently at India and also looking at Brazil. And so this week is going to be one of those sessions where obviously we'll be focusing on South Africa. Next slide, please, Lucas. South Africa clearly is a country of tremendous concern in terms of the pandemic. As far as the data allow us to know, and of course the data for many parts of the region of Africa, or sub-Saharan Africa, are very, very limited. But as far as the data show, South Africa has been the most affected country in the region in terms of cases and in terms of deaths. And it now seems like we are entering into a third wave. The data here are for deaths. If you looked at the data for cases or hospitalization, you would see a much more pronounced beginning of a third wave in South Africa at the moment. In fact, I would strongly advise you not to focus too much on the absolute numbers on the left-hand side here in terms of numbers of deaths, because next slide, please. These are really, to some extent, no, the previous slide, please, a bit of a tip of an iceberg. Previous slide, please, Lucas. Thank you. And certainly according to data and estimates produced by South Africa's Medical Research Council, although the official numbers of COVID deaths as of a few days ago were about 58,000, excess deaths, so the number of deaths which is greater than you would have expected over the pandemic period, is about 170,000, so more than 3 times the amount of the numbers we saw in the previous chart. And the large majority of those are thought to have been caused by COVID, but often a cause of death hasn't been attributed to those deaths. And people aged over 60, as far as we can tell, account for more than 3/4 of excess deaths. So they account for about 130,000 excess deaths so far since the 3rd of May. So these are data from South African Medical Research Council, and we wrote this up a little bit in a blog post, which, as you can see at the top of the page, was posted on the Global Platform website a few days ago. So next slide, please. So it is important not to lose sight, because it's of course one likes to work with official numbers and compare South Africa to other parts of the world on, you know, sort of John Hopkins databases, etc. But the true pandemic curve of mortality probably looks rather more like this red line than the official line that we can see beneath. So the shape of the curve, the trend of the curve is probably a fair reflection of what's going on, but the absolute numbers of deaths would appear to be considerably higher. Next slide, please. Just going to touch on a couple of quick things that will be particularly, it's also useful just to bring people up to speed who aren't familiar with South Africa. As far as I understand it, vaccination began in South Africa in February, and most people have said that it's been an extremely slow, frustratingly slow process, partly because of supply issues of vaccine. Certainly, I've been seeing lots of reports of major barriers in terms of digital literacy or access in rural areas for older people to be included in vaccination programs. Next slide, please. And here was a chart I just found yesterday, which I think has caused a concern, really. So this is the percentage of people aged 60 or more who have registered for vaccination. So they haven't had the vaccine yet, they've just put themselves down to be vaccinated. So as you can see in the bottom right-hand corner, just over half of older people in South Africa have registered, although in some areas, such as the Northern Cape, it's more like a quarter. And I think, you know, clearly that's particularly concerning. And although coverage, I think, of health workers has been pretty good, now I believe the government is talking about rolling out the vaccine to people under the age of 60. And that, I think, is a concern when so many people over the age of 60 are yet to receive a single dose. Next slide, please. Lockdown in South Africa. There was a lot of concern about what was quite apparently quite a strict lockdown and quite a strongly policed is the word, lockdown, during several months of 2020. Next slide, please. As I understand it, there is now, previous slide, please, a ramping up of lockdown legislation in South Africa. I think we're currently at what's called level 2, which doesn't seem to be too draconian. It seems to have more to do with social distancing and sale of alcohol, but isn't necessarily a massive barrier to some South Africans to go out and gain a livelihood. And of course, as I'm sure we all know, South Africa has got an excellent system of pensions, of old age grants for older people, which hopefully have mitigated some of the economic and social impacts of those lockdowns. So that's my sort of whistle-stop tour of South Africa, which hopefully sets the scene a little bit, especially for people who aren't specifically familiar with the country and what's been going on in the last few months. I'm now going to briefly hand over to my good colleague, my bearded colleague, Lucas, who is going to explain how you can ask questions and get answers during the session. Lucas, next slide.
Thank you. Thank you, Peter. Welcome, everyone. We are broadcasting in YouTube, and you both can ask questions through the Q&A button or also in the chat. And if someone else is looking at the streaming in YouTube, I also be looking at comments there. So you can either use any of the methods Zoom provides us. Thank you.
Thanks, Lucas. Next slide, please. Well, it's at this stage in the sessions that I always hand over to our guest chair, our chair for this particular webinar, and I'm absolutely delighted. It's brilliant to have Dangwa Nuyu from the University of Cape Town, who is going to be our chair. He's an associate professor in the Department of Social Development and former head of the Department of Social Development. He has a PhD from the University of Witwatersrand, an MPhil from Cambridge, and a Bachelor of Social Work at the University of Zambia. He's published books recently about social welfare, social work, and social policy in post-apartheid South Africa. He, as I understand it, isn't somebody who primarily looks at older people, but this is something that we like to do in these sessions, is to bring somebody who clearly has some related expertise, but isn't one of what you might consider to be the usual suspects, the people who primarily work on older people. And we all know each other very well, and we tend to hear very similar things, so that he can bring some perspectives, particularly from his expertise in social policy and social work, which may not be so obvious to those of us who primarily work in this area. And a few months ago, he published an excellent paper on South Africa's social policy response to COVID. And I'll post the link in chat to that paper. And among other things, he noticed how difficult it was for social distancing to happen, particularly in crowded informal settlements and townships. And I think this is interesting, he was very positive about what had been achieved and said it was interesting to see how political will was suddenly discovered by government officials during the pandemic, that suddenly things that hadn't seemed to be possible became possible. So I'm sure he will add tremendous value to our session and also be a wonderful chair. So Dangwa, the floor and the chair are yours.
Well, there we go again with this technology and everything that is pertaining to these Zoom sessions. But again, it reminds us that technology has actually brought us together. from different parts of the world. So that's a plus. So thank you so much, Peter, for inviting me and for my colleagues also to giving me this opportunity to chair this session. Very important, I must say, in these trying times. But as you rightly pointed out, being a social policy, social development expert, and having a global perspective, one is also bringing the lens that actually captures different vulnerable groups and how they are impacted negatively by this pandemic. And from a social policy and social development perspective, one begins to actually sharply bring these issues to the fore through the high levels of inequalities that are embedded in the social fabrics of not only African countries, but even in the developed North. And also the grave economic situation that has been engendered by COVID-19. So without further ado, I will introduce the first panelist for today's session. Her name is Roxanne Jacobs, and she's based at the Center for Public Mental Health at the University of Cape Town. She's part of the South African team that is participating in the International STRIDE project on strengthening responses to dementia in developing countries. Roxanne, the floor is yours, and you have 15 minutes, and then we will, as Peter rightly pointed out, take your questions pertaining to your presentation at the end of all the presentations. Thank you very much. Over to you, Roxanne.
Thank you very much, Jay. Thank you, host, for this opportunity. I'm sharing my slides. So I'm going to be talking today about the factors increasing risk of elder abuse during the COVID pandemic in South Africa. And this work is based on an elder abuse study that is, well, a sub-study that's nested within the STRIDE project. And it's also part of my PhD. And these are my co-authors and my supervisors. But it's also to acknowledge the larger Work Package 7 STRIDE team. So I'm going to jump right into it, give some background in terms of elder abuse globally and in South Africa. We know that elder abuse is a hidden problem due to underreporting. About 4% of cases are believed to be reported. Globally, 1 in 6 persons aged 6 years and older have experienced some form of abuse. And for persons living with dementia, that total is about 2 out of 3 people who are estimated to experience some form of abuse. In South Africa, we don't have any national prevalence data on elder abuse or on dementia. There are a few localized studies that suggest that the rates are high. One study in particular mentions that women and persons with dementia are high-risk groups. And another study done in the Mafeking area, quite a small sample, but it indicated that men are at increased risk for physical abuse, whereas women are at increased risk for emotional, sexual, and financial abuse. In terms of the methodology for this particular piece of work, it's nested within the STRIDE project, like I mentioned before, specifically the Work Package 7 work. It's a situational analysis that looks at the cost of dementia in society within South Africa and works towards informing a development of a national dementia plan. So this particular sub-study provides a situational analysis of the support and care provisions for elder abuse. So the phase 1 was looking at a desk review guided by the STRIDE topic guide, which comprised about 15 thematic areas, which also included the World Health Organization's global dementia indicators, and also performed a SWOT analysis, looking at the strengths, weaknesses, opportunities, and threats within the care and the social support sector. Then we followed up with a phase 2, which was to do interviews with stakeholders. And we spoke to participants from the National Department of Social Development. We spoke to individuals from the long-term care sector, the NGO sector, traditional healer, as well as persons living with dementia and a carer. So we were looking to find out what are the possible factors that could impact on elder abuse during the pandemic. So these are just our initial findings. So I'm going to first describe the pre-pandemic situation across different areas, and then now I'll highlight what was the impact of COVID-19 and what that implies for the risk in terms of elder abuse. So in terms of our socioeconomic situation, South Africa is one of the most unequal countries in the world, with high rates of poverty and unemployment, and pensions often being the most stable household income. So with the pandemic, of course, this has exacerbated these inequities with reduced income or loss of income, with the informal sector where there are these no work, no pay norms being most vulnerable, creating financial as well as food insecurities. This, of course, increased the pressure on the pensions to sustain entire households. This was already the case before, but has obviously amplified that situation. And for example, where there's a substance abusing member in the family tormenting the older adult for money or for whatever reason. Also increased family violence and also increases the risk for elder abuse. These socioeconomic situation and these factors are also known determinants for crime and violence in the country. We have notoriously high rates of crime, where we have about 7 times higher the global average for homicide rates. And about 25% of women experience some form of intimate partner violence in their lifetime, and also high rates of fear of crime. During the pandemic, this, of course, also increased the determinants of this crime and violence. We've seen an increase in unemployment, but if you look at the expanded unemployment rate, which includes individuals who also stopped looking for work, this is just over 42%, which is quite high. We've seen with the initial lockdown that other forms of crime, contact crimes, seen a decrease with the initial hard lockdown, but we've seen a major increase in interpersonal violence, specifically gender-based violence, which was reported to be about 500% more in the first 6 weeks of hard lockdown. Right. There are also pre-pandemic, there's also been, we do have social cultural contexts that need to be taken into consideration, with stigmatization of individuals as well as harmful beliefs that play a major part. We have various cultures in South Africa, and this varies within cultures as well, where the origin of misfortune or illness is believed to be social or spiritual in nature, where, for example, individuals living with dementia and unusual behaviors that is associated with this are viewed with suspicion and evokes this fear of what the community is going to do when these symptoms are seen or individuals exposed. So this leads to self-isolation or hiding a family member, and of course affects the help-seeking behavior in delaying or preventing that. During the pandemic, we've of course seen an amplification of this, where it's increased isolation, confinement, and restricted access to information and help. Of course, causing emotional strain, loneliness, and generally unsupported older persons and families, fear, anxiety, and stress. Now, if you put this in the context of the socioeconomic situation that I described earlier on, this creates a scenario and a situation where older persons are dispossessed of their pensions, incomes, property, material possessions, and increasing that risk for various forms of elder abuse. Our healthcare system, also known with historical inequities. We have a public healthcare system that provides services to about 80% of the population, which is quite overburdened. And we have the state that relies on the NGO sector and the private care sector to provide dementia-specific services. So with the start of the pandemic and the focus on infection control and management, which of course is important, we've seen a discontinuity in services and treatment and an increase of fear of contracting the virus that also prevents help-seeking behavior, which has generally left persons unsupported within the community context. The long-term care sector, I'm not going to say too much about this because we're going to have Leon and Gabrielle speak about this later, but I'm just going to say that we have a funded and a private care sector that caters to the minority of South Africans, and also community-based care that comprises family carers where the older person in need of care is cared for at home. And if they do provide services, or that's normally provided by NGOs, a sector which is also a struggling sector financially and resource-wise. And then there's also a problem with unregistered facilities, which are mostly predatory in nature and don't comply to the minimum norms and standards for good caring for older persons. Then with the impact of the pandemic, we've seen a destabilizing in the care facility funding model with loss of income, some even closing down, and of course, isolation, confinement, and restricted access to support. This, of course, creates an environment where families and communities who are providing care to an older person, where they do need care, is unsupported in a context where there's increased family stress, working from home conditions, loss of income, dealing with those issues, homeschooling of children, and it becomes a pressure cooker environment in the community setting and within the home environment. We've seen an increase of stress, caregiver burden, and burnout. And this is amongst facility staff being increased, having an increased workload, and family carers being cut off from the usual social support networks. So this time, I think, really has emphasized the need to strengthen community-based services for that aging in place with dignity. In terms of our judicial and social protection situation, our services, well, we can still see the inequities in access to justice and protection services. We currently have no national helpline. There's no elder abuse or NGO support services available, specifically for that. There's also no national prevalence or reporting or monitoring. So there's definitely a reluctance to report amongst professionals and community members because, as our participants were telling us, people don't want to get involved. They also don't know what's next, what comes next. Once you report it, then what's going to happen to the person? Is that uncertainty? We do have legal aid services available, but these are not sensitized to people with disability and certainly not sensitized to how to support people living with dementia who has justice needs. There's also an urban bias in these services allocation. It's often a physical problem to access these services. And they only focus on the criminal matters and not really supporting any civil matters, which older persons may also need. So of course, with the pandemic, we've seen inequities in access being amplified, as well as the isolation and restriction on movement where that is concerned. So as a result, elder abuse remains hidden. In this situation, there's this uninterrupted exposure to risk where older people and people with disabilities, and certainly people living with dementia, are unsupported in accessing justice and social protection. So in terms of some gaps identified through the situational analysis, data is very important. We need data across the sectors. This is including the care sector, policing, health, social protection, or judicial. And we need these systems to speak to each other so that we can get comprehensive picture of what's happening in the country. We also need research on and some conceptual work done on the cultural manifestations of elder abuse, because it varies across contexts and it varies across regions. We need to understand this more. Routine reporting and monitoring. We need a national helpline. We need a coordinated support and intervention response that is accessible and multi-sectoral. Because currently we don't have a real long-term care system that supports carers or families in the communities where most of older persons reside and need support. And we don't really have an accessible port of call for older persons in the community who are in an abusive situation and seek help. So it is unclear what is the pathway of care and support for people looking for assistance and support regarding elder abuse. And are these culturally acceptable? Are they even appropriate? Okay. It's not all doom and gloom. We have a lot of challenges. We have a lot of things that has been exacerbated by the pandemic. But there's also been some positive responses. We've seen some positive responses from the state in terms of providing a COVID relief grant to help combat financial insecurity within the homes, distribution of food parcels, also prioritizing people 60 years and over, and long-term care facilities for the vaccine rollout. So that was quite positive. And after more than a decade, when the Older Persons Act mandated the development of an elder abuse register, we haven't seen this happen yet, but we're seeing now that there's talk about moving this to an electronic form and also to sync this information with data from the Department of Justice. So that's quite positive, and there's talk that it might even come about in the next year or so, which is we're looking forward to seeing that happen. There are community structures in place, for example, senior citizen clubs or community centers where formal elderly services can be built in. So it's not about reinventing the wheel and starting from scratch. There are things, positive things and services happening that we can just strengthen and make sure that this is also part of that mandate. Some takeaway messages. Clearly, the pandemic hasn't affected everyone in the same way. We need to strengthen the social care and support sector. For example, we need to have sustainable funding model for NGOs who provide critical services to older adults and their families. We have the state relying on them for all of these specialized services, but there's really not enough funding or capacity to provide or cater for the need. We need accessible and specialized support services for elder abuse specifically. We need a helpline that is linked to a coordinated response. And we need to empower people to report and to follow through, because if elder abuse remains hidden by those who know about it, we need to make sure that we need to get people to a point where they feel empowered enough to get involved and not just look the other way. And this is professionals and community members, family members. So basically, we need a swift response and justice for older persons within their lifetime, because these processes take way too long and justice is a human right. So it needs to happen within their lifetime. Yeah. That's all for me. Thank you.
All right. Thank you so much, Roxanne, for that insightful and brilliant presentation. I'm sure people have got lots of questions for you at the end of our session. The next panelist is Francesc Xavi Gomez Olive, who's an associate professor at the MRC VITS Rural Public Health and Health Transitions Research Unit, better known as the Anginkoek Court DHS, operated by the University of the Witwatersrand. He's also affiliated to the Harvard Center for Population and Development Studies. His research interests include the health of older people, including HIV, non-communicable diseases, and other conditions. Francesc, over to you. Xavi?
Can you hear me now?
Yes, yes, we can.
I did the same thing that you did before, sorry.
Yes.
Thanks, Mdawa. Thanks for the presentation. Yes, I'm gonna talk about the research and also mostly the pre-COVID situation that we had in the study site, and then some of the studies that we have done in Agincourt. Now it's not moving. Oh yeah, now. Then the study site was started in 1992 and is 500 kilometers north east of Johannesburg in Mpumalanga province. And in this area, we have been following a population on this health demographic surveillance system that consists on an initial census. You're following this population every year, and then people can come in or out of the population by birth and in migration, or they exit by death and out migration. At present, we are following around 120,000 people that live in 31 villages and are distributed in 21,000 households. The area is rural, but is quite density populated. The education level of the population, especially older population, is very low. We have high levels of illiteracy in older population. Now this has improved, and many villages have primary, and some of them have secondary schools, and the population that have tertiary education has increased. still we have high levels of unemployment, and then that forces internal migration in South Africa, with around 60% of all the men 35 to 60 years old internal migrants. And it has increased in the last few years also that women have joined the migration labor force. Then the area still have poor water supply and sanitation, although electricity is well distributed now. And the area is covered by 7 primary healthcare clinics, 2 health centers, and we have 3 district hospitals that are 25 to 60 kilometers away of the study site. As a background of the population where COVID came, we have seen huge aging of the population, a process of aging of the population.
Sorry, Shavi, sorry to interrupt, it's Peter here. Your slides aren't actually changing. So I can see the aging population slide on your left margin, but the main display is still the first slide.
Oh, really? I don't, can you see them moving now?
No.
Because they are moving in my screen.
They are stuck, Shavi.
Maybe if you leave screen sharing and then come back in again, that might possibly work.
So we have on the left side, they are not moving, but they're stuck as well.
Then do I stop sharing then?
No,
maybe if you come out of screen sharing and come in again, it will load up properly.
Well, and show.
There we go.
Can you
Now
see
we
that?
got it. Yeah, it's good now.
You can see it now.
Yes. We're seeing the age pyramids now as our main
Okay,
view.
then I mean, sorry about that. Then I'm going to reduce the site, and hopefully you can see a little bit what is going on here. Sorry about that. Then I mean yeah, what I was saying is that the population is aging, and we had this pyramid with a very young population in 1992, and we see the progression of the population, and we see the base of the pyramid that is getting smaller, and we see now that we have 13.5% of the population in the study site that is 50 years and older. And then we also have very high levels of HIV in this population, with 23% of population of the older population being HIV positive. And unfortunately, we can see that in the treatment cascade, the population are not well covered with what should be these columns. These pink columns show this 90% that we should have on the 1990. And actually, if we see together what they self-report and what we have been measuring in this population, we are on around 70, 50, which is not what is needed at this level, I mean, of the epidemic. And also with blood pressure, we have this subgroup of 40 to 60 years old that we have been following, and we see that the blood pressure, the hypertension is very high at these younger, older ages. I mean, we're talking 40s and 50s here, with around 40% of men and 50% of women being hypertensive, but only a third of men and under 50% of women being hypertensive. This is in younger age groups. If we went to the 60 plus, then we will be on around 67% of the population being hypertensive. Then on top, I mean, this is just to show that, I mean, we have this population when COVID arrives to this population that has already a lot of hypertension, a lot of HIV, the health systems are already stretched, and we have high level of the population here. We have around 69% of the older population that are multimorbid, that have more than at least 2 conditions, and 38% that have 3 conditions or more. And then this is also a stretch of these health systems and the situation of this population. The mortality of this population, we have seen also here, we've seen the right on the right in 2018, 2017, that the main cause of death of this population in general, but especially the older population, are cardiovascular diseases and chronic conditions. And also we see that when we have a subgroup, it is a cohort of 55,000 individuals. When we are in the aging of the population, the number of deaths due to cardiovascular diseases are increasing and the becoming the first cause of death of this age group. Then this is a background of what the situation of the population when COVID arrives in 2020. And then we did some studies. All the data that I have here is a preliminary data. We haven't completed more than just the first study I'm going to present that we just recently published, but we are working on following the COVID epidemic in this population. And what we had to do at the beginning was to do phone calls, because we started this study on together with other sites of South Africa from the South African Population Research Infrastructure Network, SAPRIN, one site in KwaZulu-Natal and another site in Limpopo. And what we did was that from our health and demographic surveillance system, we called 750 households and we follow them in calls every 2 weeks. Then we show here the level 5, level 4, and then here we see when we started the calls on different sites. Red is KwaZulu-Natal, gray is Agincourt, and the blue is in Limpopo. And then we see that we covered all the first wave and beginning of the second wave on these calls. Then what we observed here is that the knowledge that people had on the measure on on COVID-19 in general increased with the months of in 2020. People were kind of behaving in the sense of not having visitors at home and not leaving home, except, we had the problem of KwaZulu-Natal, where people were more mobile than in Agincourt and Limpopo. And we see, as I was saying before, Roxanne, that this social distance was really complicated, and avoiding crowds and avoiding transport was not at the level that should have been. But the use of face masks was started relatively low, or very low, and very quickly increased to nearly 100% of people following. Then the other interesting thing, and I will talk also a little bit more later in the other study, but we see that around 50% of the people, and we have to think that this older population need to go to get the HIV treatment, all the chronic conditions they need to get every month or 2 months to collect the medication. And around 50% of them said that they missed medication in the previous 7 days. But interestingly, they don't complain of and they not having access to the health facilities. And what we think is that people were scared of going to the health facilities and they were missing their medication. Also, the loss of earnings was not as expected, and possibly because a lot of people in these sites and in Agincourt are living depending on the grants. And actually, there was an increase, as Roxanne mentioned, of the grants for a period of time. And then some people actually increase a little bit their income in the houses. And then here, the last two is on mental health, on the patient health questionnaire and the generalized anxiety disorder that we saw. It was constant. We didn't see the increase that we were expecting on depression and anxiety. The other thing that we did was we have been following this population in the clinics, and we have analyzed if 2020, as we saw in the previous slide, was affecting the access to clinics and to receive the medications that they needed. And we see that people reduce the number of visits that we had or that we saw in these 7 clinics and the 3 hospitals but this is mainly clinics, sorry, this is clinic visits. It was reduced actually for all chronic conditions, also for HIV and hypertension separate, and diabetes, that was the most affected one. And we see when we compare the 2019-2020 for multimorbidity, that we also see a reduction of people attending clinics and receiving, of course, the medication that they need. When we see that by age groups, we see also that women normally are attending more to the clinics than men, and the reduction was huge. It was bigger than in men in number of women that stop attending clinics, and we saw also a reduction in men. And when we look at age, we see that or younger age groups that are the ones receiving mainly in these clinics HIV treatment had a reduction on visits, but also we saw that in the older ages, that is what we are discussing now. Then the other study that we did was the a subsample of 2,000 adults. And what we wanted is to track individuals, and this time we're asking them about the households and the structural factors that impacted adherence to prevention guidelines and risk of infection for COVID. But this was more follow-up of individuals, and we were asking about different areas related to COVID. And then in here, we see that especially in, older age people, this is all self-reported, but this was at the end of 2020, we have that also reported 30% of these self-reported infections, although the numbers are very, very low, were in all the population. But interestingly, we didn't see symptoms. And there is another study that we are doing where we have around 30% of the population that have seroprevalence of COVID. And again, we don't see any symptomatologies. I think it's right around 5% of the population only that presents symptomatology here. Then in here also is the prevalence of the compliance of all the measures. And when we are asking population 50 plus and 60 plus, they are the ones that comply the least compared to the younger age groups. And then what we also discuss, we were asking also were about the household income and how the COVID had affected them. And we see that around 43% of the people say they haven't changed. It's 30% that have reduced their income, and around 25%, and that's an interesting thing, that had actually increased their income. And possibly this is because of the grants that all the people are receiving, and these are incomes that are entering into the house. And then here on the right, we see that mainly when they didn't have enough income, they just had to reduce income or start growing their own food when they could do that. And in the food insecurity, we ask about if they had suffered any shortage of food in the last month, and we saw that 33% of the households, they reported having this shortage of food. And when we are seeing the distribution of food parcels that it was done during this period of time, we saw that people of households that are moderate or food insecure, they actually were not receiving, very little of them, around 15% of them actually received the food parcels. This means that the distribution was not done in an equitable way in this site. Then for the conclusions, we see that Asian group population is aging, and that we have high prevalence of chronic underlying conditions that we will explore, but it may affect the outcome of COVID cases. We have this increase of cardiovascular and chronic conditions in mortality in all the population. knowledge of COVID has increased, and people are following the non-medical criteria or rules that have been proposed. Although this is 2020, now it's much less than it was before in the first and second wave. And COVID may have reduced clinic attendance and adherence to chronic medication, and that's important in women and older population. And then we saw this reduction of 30% of households on income and food insecurity also in around 30% of households. And that's all for now. Thank you very much.
Thank you so much, Xavi Gomez Oliva. That's kind of just getting into the Spanish side of it, of the pronunciation. Very insightful and very critical issues have been raised in that presentation, and then we'll bring them to interrogate them at the end of the presentations. I'll go straight into the introduction of the next speaker. Leon Geffen is a family doctor based in Cape Town. He's the executive director of the Samson Institute of Aging Research and honorary senior lecturer in the Institute of Aging in Africa at the University of Cape Town. Leon has worked with Western Cape's Department of Health to develop a public-private partnership for the delivery of primary care services to older persons. He also works with the World Health Organization in a number of related areas. Leon, the floor is yours, so to speak. Over to you.
Good afternoon. Thank you very much for having myself here, and also Gabby, who has collaborated a little bit with me on putting this together. I'm not sure if I can share my screen, Lucas. I'll try and do that. Okay, here we are. I can share my screen.
Yes,
and, okay, thank you very much. I'll just go. Just let me know if my slideshow is going to work.
Yes.
Please let me know if it's okay. Can you see my slides?
Yes, I can.
So I'm going to really keep it very, very simple. I think many of us, and I'd welcome interactive discussion on this. And I'm going to give mostly a qualitative discussion rather than a quantitative discussion, because one of the things that I think we've all become aware of is that talking about COVID stats and numbers is a moving target, and what we present today is no longer current in 7 days' time. So I just want to just keep it as simple as possible and talk about a little bit about what we are finding in long-term care facilities and just my general impressions of having worked in the field for the last 15 months now with regards to COVID and older persons, 16 months or so. I think, Peter, we published one of the first editorials in BMJ around what we saw as going to be happening. And one of the other things that I'd just like to commend Peter on is in March last year, Peter put together some sort of modeling on what COVID could potentially do to older persons. And I think many models have been shown to be incredibly poor. But in fact, when I looked at Peter's data, when I reviewed it about a month ago and looked at what we had predicted in the Western Cape, it was really within probably 2 or 3% of the of what we'd predicted all those months ago. So Peter, kudos to you and your team for putting this together and getting it all done. And I think what we need to do is to look at long-term care and provision of care service to older persons, particularly those living in care facilities, and take a macroeconomic view of what's happened, and to maybe that could explain as to why those that are the most vulnerable are going to become even more vulnerable and be shortchanged over the next few months, many years to come, probably. And in the South African context, we've seen an enormous shrinkage in our economy. Figures looked at for the quarter ended June last year, which is exactly a year ago. Very early on in the pandemic, we saw an 11.3% decrease in the total earnings. So, and I would imagine if we start taking a look at the macroeconomic figures for the first quarter of 2021, we'll see even worse figures, despite the fact that we have come out of significant lockdown. We've also seen a total number of a massive increase in unemployment from just over 10.2 million people employed at the beginning of 2020, dropping down to just over 9.5 million. So a massive loss of jobs in a country already faced with if we want to really quantify it, probably in the order of about 40% unemployment, and certainly amongst that, significantly higher youth unemployment. We also know that the South African government has taken out loans. There's been a stimulus package that the government has put in place to try and drive job creation, protect the most vulnerable, support health and frontline services. But none of that has actually filtered through to providing care to people living in old age homes or residential care facilities. And there's this IMF loan that's been taken out, and I think most of us are aware that IMF loans do not come without significant economic issues down the line. So my final slide, and then maybe just to talk about a few points, is older persons are going to be squeezed from all sides. There's been a reduction in funding of services to older persons programs. Pretty much all programs for older persons through the lockdown have come to an end. And very few of them, now that the lockdowns have been released, are able to gear up to start up again. They've lost capacity in terms of the support services from their staff. Older persons still remain very reluctant to go out and participate in community-based programs. There's no guarantee that any of the payment for services delivered to older persons will continue and these are services that are all funded from the Department of Social Development. And I'll just touch briefly on how funding in care for older persons is provided in South Africa. That we have a Department of Social Development. It's a national department. We have 9 provinces in the country, and each province has to deliver according to the mandate of the national. It's a national competence in terms of providing social welfare services or social development services to the population. Contrast that with the Department of Health, which is a provincial department or provincial competence, and each province, by and large, has a certain amount of autonomy in terms of the services that they deliver according to a national mandate. However, what happens is that there seems to be some sort of silo that exists in which Department of Social Development believe they're only responsible for social development services and social welfare services, such as paying pensions and old age grants. And they do not provide any health services. Similarly, health services turn around and say a lot of the services that need to be rendered to older persons need to come from the Department of Social Development, and therefore they do not provide a lot of services that should be rendered to older persons because they believe it to be the responsibility of the Department of Social Development. Therefore, older persons fall between the cracks. And that's particularly seen now in how old age homes or long-term care facilities are being run, because certain things such as the provision of PPE to facilities, there was initially a long debate and non-delivery of PPE to facilities because DOH, the Department of Health, said it's the responsibility of the Department of Social Development to provide it. The Department of Social Development said that they did not have the budget and the funding to provide it, and therefore very limited PPE was provided. And it fell to mostly community-based organizations, non-profit organizations, to try and provide PPE to old age homes, and so that the care workers working within the facilities and the residents could actually be protected in the early stages of COVID from certainly before vaccines have become available. We know that the programs that are being run by the non-profit organizations, community-based organizations, and faith-based organizations are under severe threat. Funding's been withdrawn, and we well know that with government funding, the moment funding gets withdrawn and maybe redirected to another program, the likelihood of that funding being reinstated is almost zero. And the financial stability and the security of long-term care facilities is very, very uncertain. Facilities are not funded. Individuals living within facilities are funded. Thus, if you take, and if we just talk briefly a little bit about long-term care facilities. So trying to find information about long-term care facilities in South Africa it's a minefield. It's not only a minefield, it's almost a dark hole. There's very little information in the public domain. And one's got to try and get information from a number of departments, whether the National Department of Social Development, the Provincial Department of Social Development, who are responsible for care facilities, the Department of Health, who turn around and say that they don't have any information on it because it's not under their domain. So it's hard to know exactly how many people, and Roxanne made a very good point as to say, how many people live in care homes in South Africa? It's almost impossible to quantify. It could be anything from 30,000 to 100,000 people. We don't know how many people are employed in these care homes. Some of the research we've done shows that care homes have staffing capacity from 0.8 staff per person, per resident, through to 2 per resident. It's highly varied. The type of services rendered within funded facilities, which are those funded by the Department of Social Development, mostly the sub-economic facilities, through to the very upmarket private facilities, are highly varied. There's no quality indicators that are implemented. There's very little review and oversight. A lot of the indicators that's required are more about process than actual outcomes in terms of the services delivered to older persons, and we have very little knowledge. So we estimate that there's in the order of somewhere between 650 and 1,000 facilities, and these facilities have residents anything from sort of 65 through to 200 residents per facility, and there is no regulation of caregivers in terms of mandatory requirements for training in caregivers, and there's also a significant amount of there's very little skills-based training for professional staff working in care facilities. So an individual who lives in a care home is funded, but the care home itself is not funded. And how this is going to impact on the financial stability and security of the long-term care facility is that as COVID has caused significant declines in the total number of residents living in care homes, the care homes are no longer able to provide the scale of services to their residents. So a care home that would have had 100 people living in it prior to the onset of COVID would now be down to 60 or 70 people. And those 100 people, they were getting funded maybe 3,000 Rand per person in the care home. Per month, they've lost the income of the 40 people who would have left the care home through the natural attrition of death or through COVID itself, and they've lost a significant amount of income. And once again, it's highly unlikely that those care homes are going to be able to get their money back. So one of the areas that we've been working very closely on as well is now with the vaccine rollout. And I just want to sort of turn my attention a little bit to what's happening in the vaccine rollout in the country. So we know that there's enough vaccine in the country at this point. I was led to believe that as of yesterday, the Gauteng province, which is one of the largest provinces in the country, has got 700,000 doses, excess doses, waiting to be administered. Our problem is not in acquisition of the vaccine. Problem lies mostly in the bureaucratization and the delivery of the vaccines. We have a highly bureaucratized system. So we have about 5.5 million older persons living in the country. And as of the 20th of June, from the Department of Health, 2.7 million people, that's less than 50% of the population over the age of 60, have registered for the vaccine. And only 30% of the people over the age of 50, about 1.6 million vaccines have been delivered. Then that's only the first dose of the Pfizer vaccine has been delivered to the total population since the commencement of the program, maybe 5 weeks ago. We are well behind the rest of the world. We are significantly behind many countries which are very, very much poorer than us in Africa. We are, I think, at the beginning of June, we were second worst in performance in Africa in terms of delivery of our vaccines to our population. We know there's no treatment to cure COVID. The only way we can actually manage COVID is by preventing it. And vaccines are what's going to make a massive change. There's been I'm probably going to make a very unpopular statement, a politicization of the management of COVID vaccines, and that has taken priority over the science. And it's been a serious problem. And it's actually heartbreaking to know that people are desperate to get vaccines, but they can't get needles into their arms. The complexity around registering people on the electronic vaccine database system, which is only in English, which you need a smartphone or a computer to access, which you need to have data to access, which requires someone with a reasonable level of literacy to be able to access, which requires someone to be able to show that they've got a national identity document to be able to access the system. Then you need to be able to get an SMS to your smartphone to tell you where to go and when to go. And many, many people have registered on the system. As I said, 40, somewhere in the order of 49% of the population have registered. But many of them are still waiting for their SMS to tell them where to go and when to go, and are unable to access the vaccine administration sites because they are not universally notified as to where these vaccine sites are. There's been a significant lack of engagement with the private sector, and both from government and the private sector itself has to a large degree been relatively absent in the delivery of vaccines. So at this point, it is a very, very dismal situation. And if we don't get our vaccine program sorted out properly, as Peter pointed out at the beginning of the presentation, we're well into our third wave. We are going to see many, many more deaths. We have obfuscated, we have not been transparent, we do not disclose numbers properly. Peter's pointed out the fact that we've had excess mortality in the countries in the order of 160,000 people. And it's been reported by our National Institute of Communicable Disease that the total number of deaths is only 60,000. The major reason for this is that they are only counting in-hospital deaths, and they are not counting community-based deaths as part of the mortality from COVID. So we are faced with significant systemic problems. We can get it right. And it was spoken to, interesting discussion I had a couple of days ago with one of the leading HIV activists in this country. And he said to me, it was for them having gone through the HIV pandemic. And I said to them that we face the same problems that we had under HIV without the lack of delivery for HIV care in the early 2000s under Thabo Mbeki's government. And he said the big difference then was you had a president who was a denialist on HIV causing AIDS and death, but you had a highly effective state that was only too willing to deliver medications. Now we have a president who is committed to the science, who wishes to get our vaccines out and to get on top of the COVID pandemic. But the reality is we have a highly ineffective state. So that's what's happened to South Africa in the last 16 years. It is a fairly bleak picture. Hopefully we will get things right, but I remain less than optimistic that we will not be in a much better position in the next 3 to 6 months. So thank you, and I'll welcome any discussion or communication from you.
Right, thank you so much, Leon, for that quite grim picture that you have painted, but the realities have to be brought to the fore in such discourses and engagements. So thank you very much for your insights. Again, the questions will come towards the end of this session. So I'll go straight to the next panelist, introduce her. Gabrielle Kelly is a senior research associate at the Samson Institute of Aging.
Sorry to interrupt, but actually Gabrielle was a co-presenter with Leon.
Oh, right.
Sorry, no, I should have made that clearer. So we're actually on to our venerable discussant. Sorry,
okay,
I'll hand back in.
All right, so I will introduce the discussant. Thank you so much. Sebestina Kalula is Emeritus Associate Professor at the Albertina and Walter Sisulu Institute of Aging in Africa at UCT. She spent 22 years as a consultant in geriatric medicine at Kruger Hospital and is co-president of the International Longevity Center of South Africa. But just before I hand over to you, Sebestina, I just want to make two quick points pertaining to the overall presentation. The presentations that have been availed to us in this session are mainly empirical in content and outlook. And they actually are very critical for the generation of the evidence that is needed for policy decision-making, especially on the part of government. And one would argue that during the pandemic, South Africa kind of shined in the early instances of the pandemic due to this robust research culture that we have in South Africa. So one should commend panelists for such insightful presentations, but which are very important for policy decision-making and also for policy advocacy. And so we are really grateful that we have this kind of data and research that is actually important for policy decision-making. The second aspect that issue that I wanted to just highlight is the whole notion of, which Leon has really delved into, the acquisition versus the ability to roll out the vaccines, and the actual paradox where you find that South Africa has got the resources to roll out the vaccines, and yet it's behind several African countries that are actually poor. So that paradox needs to be interrogated and teased out. Without further ado, I would like to hand over to Sebestina Kalula for your insights as our panelist, our discussant. Thank you so much.
Thank you for the introduction, and again, thank you so much to the presenters this afternoon. It's very pleasing that despite the constraints that have been put on us to conduct research, that the research has indeed still continued to be conducted within the country. I'll start with what Roxanne Jacobs presented about elder abuse and the older people in South Africa during COVID. And indeed, she has highlighted that elder abuse is common and is underreported in South Africa, and is so much more common, especially in people living with dementia. And South Africa indeed is an eco-society, and has been, as has been reported worldwide, the abuse and violence is more common in poor societies than in the quite well-developed societies. The violence and the crime, especially violence against women, and usually abuse happens within households commonly, has been exacerbated during the time we have been dealing with the COVID. People who maybe spent some time away from each other, and a few hours together, had to spend long periods, which exacerbated the abuse. And as Roxana mentioned, there used to be HEAL, which was a hotline to report elder abuse, and that has disappeared. So there is no one that people can phone. And even then, if you are living with an abuser, it's very difficult to make a call and report that abuse. And as has been mentioned, both with Leon and Roxanne, long-term care sector, both community, family care, and long-term care have really been negatively affected during the pandemic, in that funding to NGOs has been reduced, and the increased number of deaths in long-term care facilities, and also people living long-term care facilities because they didn't want to live in a confined environment, has reduced funding further. And looking at the elder abuse itself, the judicial system is not really handling the cases that are reported with vigor. There is supposed to be a register for reporting people who are abusers, but that has taken long and it's yet not running. As Roxanne mentioned, there is a plan to have an electronic record for abusers. But what is lacking, as was mentioned, is there is no data, poor data, and no major research projects on elder abuse, and poor community support. The hotline, because it was run by an NGO, it needs to be supported by government if it has to continue for a long continue even when we have challenges as we have with the COVID. And looking at the other research, I think he said, call me Shadi, looking at older people and the COVID insights from Mpumalanga, which is looking at the impact of COVID from a rural part of South Africa. And as he said, within this community, I really commend the researchers. They have been conducting this research for over 3 decades. And as he mentioned, in a community where illiteracy is high and there is high non-communicable diseases, multi-morbidity, that was a challenge to manage even before the pandemic in a society that is relatively poor. And you could tell that most of the people are poor in that community because the grant that was given to support people during the pandemic is not that much. And yet it increased the amount of money that families had from whatever grant they were given. And there was food insecurity before, which was worsened by the pandemic. The distribution of such food parcels that were available were not sort of transparent. And we know that there was an outcry within the country about how the parcels were distributed. So we look forward to sort of learning more from this research, which is ongoing. And it's pleasing, I think it's because it's a non-study area that despite the poverty they were able to collect information using telephone calls, I suppose, and the other means of communicating virtually. And turning on to Leon Giffen, looking at long-term care facilities in South Africa and how they responded to the COVID pandemic. The long-term care facilities, both residential and in community, were severely affected, as he did mention. And what worsens this impact is that the departments supporting services for long-term care, they don't work in collaboration. And this came to the fore during the, now that we are dealing with the pandemic. Some of the services that were provided by the NGOs, I'm sure will not come back because those services have shut down due to poor funding. There is also the funding of the workers within the care system is between the health department and the Department of Social Development, not well coordinated. So this also was really came to the fore during the pandemic when there was a shortage of the workforce, with the people not being able to access transport or getting ill or not wanting to be exposed to the infection. And as we looked, and has been said, looking at the vaccine rollout, this has been slow within the South Africa, and though the vaccines are there, it has been mentioned that only 49% of older people are registered. Part of this is the complex registration system, but probably even the information regarding the advantages of vaccines, they have to be put across to other people in a language that they can understand. So I'm not sure how much of it is the fear of the vaccine. It's another angle of research that could be looked at. But again, as Leon mentioned, the registration system is quite complex. And there are people I've talked to who live in an area and they have been sent to an area 10 kilometers away to be vaccinated, and nobody knows why that happens. Obviously, the register is also not well managed. Again, thank you so much to the presenters, and maybe at a future date, we can meet again and see where things will be in a year or so. Thank you.
Thank you so much, Sebastiana Kalula, for that insightful summation of the events and the presentations of today. I will now open the session for questions, comments, any insights from everybody. And in that regard, I also just want to point out that we'll take maybe 3 questions at a time, and then open, and then the panelists will respond. Peter?
Hi, yeah, I've really enjoyed this session. And in a way, I'm in my head trying to put together what seem to be very talks which relate to each other quite closely. And it seems to me, looking at this from the outside, that I've learned a lot about the context of South Africa and aspects of South Africa's context, which which make the country, broadly speaking, more vulnerable to the direct and the indirect effects of the pandemic. be that the nature of the political regime, be that the prevalence of NCDs, on lots of different levels in an abusogenic environment. Now, we kind of know quite a lot about that context. We don't know very much in terms of hard evidence of what's actually happening at the moment, but we can, because data are very limited. So in the case of abuse, how do you do a meaningful survey of the prevalence of different forms of abuse of other people? There's just no way you can do it. So we don't have a lot of very direct evidence, but we have lots of inferences we can draw, either from more limited anecdotal evidence or because we know about those contextual factors that predate the pandemic. And so I started to get a pretty good idea of what seems to be going on, some of which I could have guessed, some of which I found quite surprising. One thing I would like to ask quite specifically is to Sebastiana in a moment, and she might need a bit of time to think about this, which is, I guess you know a bit, either personally or through colleagues, about how hospitals have been managing this, and how have they been particularly thinking about older people and inpatients, and considering access to treatment, and whether older people have had the same level of access as other age groups, and also whether there's been real pressure to reduce bed blocking, which was something we've seen in the UK. And sometimes, of course, that led to older people being discharged from hospital when they were a danger to the community because they were infectious, or just when they weren't in a position to be looked after outside. So there's a lot we can guess about what's going on now. But also what I found very interesting is that people are already beginning to identify what some of the longer term legacies of the pandemic, or medium term legacies, are going to be. And a couple which I saw there, which I think link across the talks. One is clearly the evidence that Xavi was able to give us from Agincourt and the other DHS sites about reduced access to medicines, reduced access to regular treatments, particularly for things like non-communicable diseases. And clearly that is going to have a legacy in terms of untreated health effects. So when we look at things like excess mortality during the pandemic, sadly, I think quite a lot of excess mortality will be occurring for years to come, because people will not have been treated, diagnosed early, will have had their treatment interrupted. And so firstly, you can see that the health sequelae are going to continue for quite a long period of time. I hadn't really thought about the grants issue, and clearly the South African economy is shrinking as rapidly as it appears to be. There's less fiscal space to spend on social policies, including cash transfers, including old age grants. And that makes me feel very concerned about the sorts of people who live in areas like Agincourt and Mpumalanga, because as Sebastiana said, the story really was about dependency on cash transfers. And if they went up a bit, some of them said they were less poor. Well, clearly what comes up can go down, and it's very likely that it will go down in the next few years. And I think this is a situation which isn't just specific to South Africa. I think there is going to be a global phenomenon of austerity on public spending and of welfare retrenchment, and that will have consequences for other people in the UK, my own country, and everywhere. And South Africa will have its own version of that, but I think that's going to be very problematic, and it will probably be affected a lot by your electoral cycle as well. So to me, I think I can see all kinds of ways in which these things tie in together, but there's a sense of having a pretty good idea about the context that preceded, aspects of context that are relevant. We've got a partial sense of what seems to be going on, sometimes very limited, because we don't actually know very much about long-term care facilities. We know even less about long-term care in the community or abuse in the community, and often they're two sides of the same coin. As we saw, our data on mortality are very potentially misleading and incomplete because of underreporting of COVID deaths. But we do also have a sense, a hunch about what the next few years are going to bring, as far as we can tell. Although, of course, we all know that trying to predict what the next few years will be like keeps on changing every month because of the pandemic. But I think there are some grounds for being concerned about some of these longer run epidemiological effects and effects of austerity. So sorry, that's a little bit of a sort of brain splurge, but it's trying to really tie together some of these issues within a framework.
Right. Thank you so much, Peter. Maybe the panelists, could we one at a time respond to Peter's assertions, because they're kind of alluding to most of the issues that you raised in the session. So I will begin with Roxanne as a response, and then Leon in that order. Oh, Leon, you wanna go first?
Yeah. Well, I'm sorry. No, I don't want to step on Roxanne's feet.
It's fine, go ahead.
Peter, the one issue I do want to sort of mention that you raised is about the bed blocking. It's I'm working both at a primary care level and as a general practitioner. I'm working in a care home, providing services, or running an administration of a care home, etc. So, but I have not found I've not had any experience of older persons not being admitted to hospital. I haven't had any sense that older persons being admitted to hospital are getting inferior treatment, and I haven't had a sense that once they get into hospital, there appears to be a sort of sense of, well, why should we be treating you for COVID because you're an old person and we'd rather be treating a younger person. So I'm not. One thing I need to say is that the secondary and tertiary level care services that have been provided within the province in which I'm working, which is the Western Cape, both at a public and a private level service, have been unbelievably good. They really have, and we need to commend the public hospitals, certainly in which the areas in which I'm working at. What's interesting is to know that currently all the hospitals are pretty full with COVID at the moment, and certainly in the Gauteng province, they're overwhelmed. And it's going to get worse, certainly in the next 2 to 4 weeks. I think we're not going to see the end of this third wave before the end of July. And many hospitals are on divert. And what's been interesting is that my private practice, which is a very upper middle class area of Cape Town, people have been diverted to the public sector hospitals because the private hospitals have been full. And it's quite amazing to find sort of relatively well-to-do people coming out and say, my goodness, I went to Groote Hospital, I went to Somerset Hospital, I went to Victoria Hospital. And these are public hospitals, and they say, we got really good care. So that's, it's heartening to know that the healthcare personnel who are working in the facilities are doing fabulous work. The biggest problem we faced, and I think is one more of a political one, and failure to deliver by the state.
Roxanne?
I definitely, look, I can't speak about what's happening in the hospital sector, but from an elder abuse point of view, we know that older people is not a national priority for the country, basically. It's become, and even people living with dementia, it's been competing with other conditions that are seen to be more treatable. So yeah, it's not a priority. It hasn't been that way before the pandemic, and it's not going to change anytime soon unless we make a lot of noise and do a lot of movement on it. I think we need to look at pathways of care to support older adults in the country. Are these accessible? We need to ask very hard questions. Are these accessible? Are they culturally acceptable? Are they appropriate? We spoke to one of our interviewees, one of the stakeholders, and told us, look, elder abuse is a form of abuse where the victim gets removed from the home and the perpetrator stays and goes about the business. So it's that dynamics. We also have to see that older people are critical resources within their families. So if you remove a person as part of your protection service, you are disabling a family as well. And you're personally affecting the victim in the most negative way. So what are we doing with our current response options, our current responses to protect the victim that is also kind of enabling and supporting that non-disclosure? It's creating an environment that is hiding the abuse. So we need to really look at what are the cultural manifestations, what are appropriate responses. I mean, there isn't a one size fits all, and especially in our country that has so many different cultures, so many variations. Yeah, there's a lot of information we don't have. There's a lot of things that we can do and build on, but there isn't the political will. So we need to get to a point where we are shaking up the ground and saying, look, this is something that you can easily fix if you do X, Y, and Z. And there isn't enough information to map out that pathway. And I think we should start there.
So if I could just have a follow-up on that, as I shouldn't be abusing my position, but the political will issue, then would you say that there's need for a political champion? Because when there was the late Minister of Social Development, Dr. Zola Square, there seemed to have been some momentum in that regard. I don't know, do we need a political champion who would actually drive that agenda?
Political champions are a nice idea, but I think in reality, it's all about shared responsibility. At the end of the day, you can't just lay it down at one department that is already overburdened. Elder abuse is a multi-sectorial, multidisciplinary public health issue. Champions are great, but we need multiple. We need a team to respond to this. If we look at services to older adults in South Africa, largely whether it's dementia care services or the aging sector in general, it's really reliant and almost completely dependent on volunteers and a underfunded, financially unstable NGO sector. So what does that tell us about how we value older people in South Africa? So yeah, we need to, there are so many issues, competing priorities in South Africa on a social level, crime, violence, gender-based violence. It's about including that, including older people in the existing agendas. I'm not saying we need to establish something completely separate. Those things never work. We have to build on what is currently there and strengthen that. And the need is within communities. So I think one thing that the pandemic has really taught us is that we need to strengthen that social care sector, providing support to families. Older people do not live in silos. They could live alone, but they don't live in a silo. They are connected in some way in the broader network. So we need to strengthen communities. And what I think is dominant in South Africa is that we can't approach elder abuse as an individualistic thing. We have to approach it in a family-centered way. And we need to combine Western models with traditional models, because these are things that are often juxtaposed, but needs to work together. So there's a lot of attention being paid to this, and that's encouraging, but there's a lot of work that still needs to be done.
Thank you so much, Roxanne. Sebastiana?
Yes, I just wanted to go back to what Peter asked about the management of maybe in the hospitals and within the healthcare system. Just to add on to what Leon said, older people, having the insight of having worked in the UK and also in South Africa, the word bed blocker, I've never heard that word used within our healthcare system. Maybe what has happened to older people is that the admission is not rejected, but maybe where the treatment is different is when one needs intensive care unit management, because there, even before COVID and maybe now with COVID where the spaces are even more limited, it depends on what underlying other conditions you have for you to get an intensive care bed or not. If we salvage this, how that other system function, after that. So should we give the bed to this one or maybe to that one who only has that element without any underlying, other disease? So in that way, that's where maybe older people do not get as much intensive care therapy as a young person with maybe zero underlying condition would. But where we need to focus is at the primary level of care. As Leon mentioned, second and the tertiary is fine, but the filter and the entry point for people into healthcare is at the primary care level. And so I think the skills there are lacking, and the people are not assessed as maybe with the knowledge that is required. So just on age without really, going into how will this person's referral to another level of care, sort of help them. So they are either blocked or sent through at that level. And it all depends on who the assessing person is. So I think we have a lot to do at the primary level of care, because that is the entry point of care for most of other people who rely on social grants, and their entry is in public primary care system. Thank you.
Thank you, Sebastiana. And Xavi?
I just want to respond to Peter and Sebastiana. The issue of the primary health care, at the beginning of the epidemic in our sub-district of Bushbuck Ridge, there were zero systems. There were zero preparation for the response. The doctors of one of the hospitals, they organized themselves for kind of an NGO, and they were going to the clinics. We collaborated with some staff, but it was quite interesting to see how they put all the systems in place, all the training of the nurses in place, and the screening tools, data collection to know how many people were going to the clinics, how many people were going to the hospitals. All these had to be put in place. I mean, of course, I'm biased as a researcher, but I mean, if you don't know the numbers, it's very difficult to know if you are doing well or not. And then, I mean, in the at the beginning of the epidemic and for the first few months, it was really complicated to understand what was happening, what was going on, where were the problems, and the hospitals, for example, we were visiting quite regularly the hospitals to understand what was the situation, and they had wards, but the wards were kind of empty. I mean, it wasn't what we were expecting, that we would have thousands of people coming to the hospital sick, and actually we didn't see that. In the clinics, I don't know if what is happening is that people stayed at home. We saw that people were not actually going to the clinics. I mean, we don't know. We have to explore that. And on the vaccine acceptance and excess mortality, this is something that we are studying that now. I mean, it's part of the questions that we are doing in the second waves of these questionnaires that we are doing. But again, it was quite, I mean, that's anecdotal, because I mean, we don't have the proper data. But I mean, at the beginning, it was a lot of resistance, even in the nurses, in the primary healthcare. It wasn't in the nurses of our team. At the end, 95% of our staff was vaccinated. And I know that the coverage in the clinic was also very high. Then I guess that that resistance will slow down as people are getting more and more people get vaccinated, but we will have to see that. And on the excess mortality, we are also measuring that. It's a pity I had to stop with mortality graphs in 2018, because I mean, you need time to analyze and see what's going on. The raw numbers we have now, we don't see a huge increase, but we are working on that, and possibly, I mean, as Sebastiana said, maybe we meet next year, we will have all these and see the counting of excess mortality. And in the final thing is, yes, the grants, I mean, many families are depending on these grants. Many families are depending on the grants of old age pension. And I mean, it's very important. And I mean, what you have been discussing now, raise this issue. I think that is something that we can start exploring also. I mean, what is happening actually when the money arrives to the house? and are they benefiting all the people? We know that with HIV epidemic, all the people were using the money to support the families and to look after the orphans, and they had a lot of responsibilities with the grants that they were receiving. We will, it's something that we have to continue exploring in the future. Thank you.
Thank you so much, Xavi. I will get some more questions. Lucas, is it possible to get questions from beyond our group?
Hi, Gangwap. We seem to have somebody who's raised their hand. I think it's Elisa Peterson. I don't know if it's possible for Lucas to enable her microphone, but it would be nice to hear from Elisa if possible.
Okay. And then, did I get a question here? Peter, you had a question. How do you distinguish between consensual pension sharing and coercive financial abuse?
Yeah, I mean, that's more of a comment, really. Well, we spend a lot of time talking about how wonderful older people are in South Africa and they share their pensions with their family members. We also spend a lot of time talking about financial abuse as part of elder abuse. So where does one end and where does the other begin? And that might, seem a rather perhaps academic question, but I think it's extremely important. You can't have a society where older people are seen as wonderfully supportive of their families on one hand, and a society where you have a lot of elder abuse on the other hand, without wondering, is there a Venn diagram going on here somewhere?
It's not an academic question, Peter. You've actually brought up something that is not only a subterranean issue, but it's actually embedded in the society, that our older persons are actually abused by family members when it's payday, pay time, when they get their social cash transfers. Some of these individuals have found themselves at risk. And there have been research studies that have been undertaken by various academics at the Center for Social Development at the University of Johannesburg. They've done some studies in that regard. So that, they've actually been able to establish the correlation between elder abuse and the financial incentive that comes with the pension. And at the end of the day, the elders are not, do not really benefit from it, because their nephews or grandchildren just come and grab the money. There's that aspect of it. But maybe Roxanne could speak more on that.
Apologies, just to interject as well. I promised Elisa I would just read out her question.
Oh, yes.
That's all right.
Yes.
Because we seem to have difficulty miking her up. And it was just this: a focus on older people living in rural areas is urgently needed. I am in a rural town 300 kilometers from Cape Town. My understanding from residents in the community is that elderly abuse is rife. So in this rural setting, 300 kilometers from Cape Town. So in a way, that's probably a good moment for Roxanne to come in, since this is a comment about abuse as well.
I think that is one of you highlighting basically a good example of what the major issues are. We suspect a lot of things, but we don't really know. But we suspect enough to know where the resources need to go. And unfortunately, it's like a catch-22. You end up resources being concentrated in areas where the needs are not always met. So yes, the thing is that translation from knowing something is rife in the community to actually having it responded to. So what are the cultural ways of culturally appropriate and acceptable ways for this to be responded to, especially when there's a tendency for keeping things in the family, dealing with things inside the family, older adults often hide abuse because the abuser is the adult child. So they don't want to get the child into trouble or disrupt the family setup and hierarchy. So there's a lot of dynamics in play. So yeah, thank you for raising that. It's a good point.
Thank you so much, Roxanne. Do we have any questions or insights or augmentation from the presenters, panelists? All right. Okay, I have something here. All right, I have someone. Oh, right, I have Mzwandile Sovanto, Dr. Mzwandile Sovanto from University of Johannesburg points out that I agree with the need not to leave those aging in place behind. Leon, it's a comment. Leon, thanks to the presentation that focused on residential care facilities. Those aging in place also contend with multiple challenges relating to food abuses, etc. Is Leon, would you maybe would like to amplify this issue? Oh,
yeah, I think that we have an enormous amount of challenges. I think Roxanne brought up one of the most important points in that older persons in South Africa, when we talk about the health of older persons, they fall under the non-communicable diseases program of the Department of Health. It's as if getting old is a non-communicable disease. Unless we change the whole narrative around how we look at older persons, work within the field of older persons, realize that needs of older persons transcend either one department of state or another. In other words, that we need to have a holistic view of older persons, and it encompasses social development, health, safety and security, housing, food security, economic development, the built environment in which they live, all services rendered to older persons. We will keep on being the stepchild of every service or services rendered to older persons will continue being the stepchild. And I'm sorry, I didn't get the name of the person who raised the issue about older persons grant, but once again, from Roxanne's talk about older persons grant, older persons form a vital part of the economy of South Africa. The social grants that are given to older persons make up a significant chunk of the national budget of South Africa. Older persons are now almost about 9 to 10% of the total population of South Africa. And I think that we are continually beating about and saying, well, the services aren't being rendered to older persons. But I truly believe that the advocates for change need to come within the sector itself, need to confront national government, confront the various state sectors, and actually take the bull by the horns. Because I think what you've got NGOs and CBOs and NPOs really swimming against the tide, and they've got limited resources. They're exhausted. COVID has really just taken the wind out of everyone's sails. One of the things I didn't mention in my talk, and I want to come back to the issue about aging in place. One of the things I didn't mention is just the failure of the bureaucracy and the over-bureaucratization of things is that care homes have been asked to fill in vaccine data for their residents on 3 or 4 or sometimes 5 platforms, the same data getting entered 4 or 5 times. It's just shocking that there's been no central coordination of this. And these are facilities with very, very thinly spread resources. Aging in place, we should all be supporting aging in place, but to provide aging in place, we need community-based services that are focused on providing long-term care to older persons. And at the moment, long-term care to older persons is being provided within families where there's no support. And let's be quite honest, as with most countries around the world, or most societies around the world, the person who is providing the aging in place to the family member is more often an adult woman or a younger adult woman. They denied the opportunity to go out and educate themselves. They denied the opportunity to go out and work and employ themselves. And they're not getting remunerated for any of the services. And they themselves are often abused. The wife who has to look after the older husband, and she herself has been the victim of abuse by that man himself, and now has to provide care to her husband, or the younger daughter who has to provide care, or the daughter-in-law who has to provide care, or an indentured laborer who has herself worked for 40, 50 years as an indentured domestic worker in South Africa, now providing care to another older person. No skills, no support, and we need to be really working together in terms of figuring out how we find solutions to these problems, and actually tasking and taking government to task for it. We cannot sit back any longer and just be quiet in the face of what we're facing.
Thank you so much, Leon. There's a follow-up question from Elise. She asks, the question remains whether healthcare workers' skill sets in rural areas are explored / used to partner healthcare workers in urban areas to bring science to rural areas as well. That's open to the panelists, but she's following up on the earlier question that she posed. And I think at this juncture, I will also hand over to Peter, given the time as well.
Well, thank you so much, Rango. You've done a great job. And, you know, I think there's been a lot of value added in this session, bringing together these different perspectives. I would just like to follow up one very quick point on the pension side again, which is an argument that has to be made by everybody really, is that old age grants are not what you would call a sunk cost. You don't just put money into that and that money disappears. That is a form of social expenditure which is recycled often within local communities. It's often spent on small businesses, and these will be the businesses that are providing livelihoods for other people who are struggling during the pandemic. And that's especially the case in rural areas. So that money isn't money that's somehow being lost, it's just being recycled. And I think it would be very useful in some of these DHS surveys where they ask older people where they spend their money, you know, they spend it on food or on, you know, whatever it is, to ask them if they're spending their money on local businesses, because I think that will provide a powerful argument to sustain those benefits during times of fiscal austerity. I can see that Gabby has got her hand raised, and so yeah, Gabby, please, I'm sure you've got something important and useful to say.
I just wanted to just add on to your point. I mean, the one thing that is protecting South African pensions and social grants in general is just is politics and the demand for there to be some kind of income to so many people who don't have. And the one thing that has positive that's come out of COVID is the introduction of the COVID grant, the 350 Rand or odd, that's been distributed not to older people, but to the general population, which has, you know, become kind of almost like a basic income grant, which has been something that's been pushed for. And this has even been now the government itself, the Department of Social Development, very Diwe Sisulu, who's kind of quite a conservative person, is even kind of promoting this. And I think the recognition that pensions are developmental in South Africa, and that they support children, they support education. I find it highly unlikely that the government's going to be able to backtrack on something like old age pensions. I mean, in a way, I feel that they might not get the amounts increased dramatically over the next few years, but it's highly unlikely that it's too politically important in South Africa to just maintain the kind of ANC's powered. That's all I wanted to add.
Oh, that's great. I think it'll be a lack of indexation if it's anything to inflation. But yeah, I don't think it'll be a reduction. But hopefully even that won't happen, as you say. Great. Well, I've learned an awful lot. I hope you've learned an awful lot. I've got lots of food for thought. I've got lots of things to process. I'm immensely grateful because I know everybody's webinared out. We've had so many of these sessions, and you know, and so thank you so much for putting your time into this, because I hope it hasn't just been another webinar, just another of those things where you show up and you turn off your camera, and you know, I hope you've got something out of it too. So thank you to Xavi, to Leon, to Roxanne, to Sebastiana, to everybody, and especially to Dangwa, who I think has done a great job, and hopefully he's got something out of this as well. I've just got a couple of quick slides. Lucas, the first one is this. And I'd love to finish on this now, because it's great when the Director General of the World Health Organization says things like this on the record. There is a disturbing narrative in some countries that it's okay if older people die. It's not. Okay. Now, in South Africa, it would seem that about 130,000 older people died this year, more than would die in a normal year. So that's a lot of older people who are dying, be it of COVID or be it of something else. And it's not okay for older people to die of anything necessarily. So this isn't an argument which is specific to COVID. And so I think that's always a very useful thing to be able to quote back to people. That is the line from the Director General of the World Health Organization. Talking of UN organizations, next slide, please. I would like to give a plug to this meeting, which is another webinar, but I think it's a very important meeting being hosted by UNDESA. They are the lead organization for the United Nations Decade for Healthy Aging. So this is going to be an extremely important meeting. I know WHO and other UN agencies are going to be involved in it. So please take a note of the meeting. It's a focus on older people in low middle income countries, and it will be taking place next Tuesday, 7 o'clock Eastern Time. And finally, we ourselves at the Global Platform, next slide please, Lucas, will be having our next webinar, and we've already organised it. We sometimes don't already organise our next webinar, but we have already done that in conjunction with the British Society of Population Studies, who are very kindly helping us with this. And this will be on the demographics of COVID and older people in low and middle income countries. And we've got some great speakers lined up for that on the 16th of July. So finally, I would like to thank Lucas, who does all the technical stuff behind the scenes, and everybody who's here today. And yeah, stay well, stay safe, stay sane, and let's keep on trying to do what we can about this pandemic. Thanks, folks. Goodbye.
Bye.
Thank you.
Bye.
Bye-bye.